We need to talk about our chat with, well, we call him Dr. Phil or Philip Spinella,
Yeah.
Professor Philip Spinella, who is a researcher and clinician from Pittsburgh. So we had a chat with Mark Yazer in the past about blood products and so forth, and he put us on to Philip Spinella. Now, Philip Spinella's got a little bit of a biography, I believe. If you Google his name, you'll find out that he's written over 200 research papers. He is the author of the book on damage control resuscitation. So if you get a chance, that is a fantastic book. And when you watch the recording that we've got, you'll notice it's sitting just over the top of his right shoulder. So have a look for that online, and I'm pretty sure you'll be able to read it. It'd be well worth spending the time and actually having a good read of it and seeing what it's got to say. But we had a good chat, didn't we, Alex? What did we learn out from Phil?
Oh, we did. Look, I took so much away from this chat. In particular, was this sort of notion around pediatrics. So this guy's got a ton of experience in peds and trauma and transfusion. Going through a university, we're always taught, kids are not just big adults. And I think, mate, that notion, that's what drives people's fears around seeing pediatric patients, because you think everything's different. What sort of Phil got through to me, the way he was talking, is, look, largely they're pretty similar. You got to treat, you got to do, just sort of tweak the doses. And so hopefully people pick up some tips and tricks on how to treat pediatric patients. What else did
The big thing for me, mate, is how dirty normal saline is. You speak to, Mark that we spoke to and to Phil now, they would literally be pouring saline down the drains if they had the opportunity, mate. They really want a service that's not delivering pre-hospital saline to trauma patients at all. So I think we're a long, long way off that ever happening here in Australia. But it will be interesting to see what happens in the future. Obviously, there's a lot of research behind this, which they have both done. Indicating that it's far better off if you're giving the patients whole blood products. So watch this space, I reckon.
Yeah, absolutely. Another interesting thing that I learned from Phil was, we ask people at the end of the podcast, what's sort of, a key thing if you were to learn medicine from the start, or what would you tell sort of people starting to learn it from the scratch now? And he had a quick answer, didn't he? Other people might think about that, but he was like, no. Straight away, here it is. You have to ask why. It's the most important question in medicine.
Yep.
Why are we doing stuff? And then he tied that beautifully, and I thought, to permissive hypotension. So we're talking about trauma and bleeding, and people sort of know, well, you got to keep a low blood pressure. But then questioning, that evidence that you have to keep a low blood pressure, that's from the era when we were giving lots of saline. So, if the option is permissive hypotension or filling someone with toxic, salty pasta water, well, of course, it's better to keep the blood pressure low than doing that. But is this notion true in the area of pre-hospital whole blood? I don't think so, mate. What do you reckon? If you had access to warm, hot blood, you get the pressure up a little bit. Don't worry about 90, get it up. I guess you got to factor in comorbidities and stuff. But yeah, that was valuable lesson to sort of, if you ever told anything, you got to do this, you got to do that, you got to ask why. And then if that evidence is 30 years old, things might have changed.
Yeah. Well, enough of us prattling on about it. I think Phil left us with saying that salt water is only good for pasta, mate. So I reckon
that's right.
Does that. Listening to the podcast, I reckon there's some good tips and tricks that you will learn.
For sure.
Take
Let's
the time.
go.
Good on you.
Play the song.
G'day. So welcome to another episode of Pre-Hospital Nerds. And lucky for us today, we have got another specialist that's joining us also from Pittsburgh. We've got Professor Phil Spinella. Is that we're calling Professor, or do we call you Dr. Phil?
You can call me Doctor. You just call me Phil. It's all good.
Call you Phil. There you go. Phil, thank you very much for joining us today. Phil has got a wealth of experience in the pre-hospital environment, and a lot of that stems around blood and blood products and so forth. And also, I was reading a lot on TXA as well. So we're going to have a bit of a chat about that today, if we could too. But Phil, can you just give me a bit of a rundown on your background, if you could, please, mate? That'd be wonderful.
Sure. I'm actually a pediatric critical care doc by training. Was in the U.S. Army, active duty for 12 years. Deployed to Iraq in early 04, 05, And that's when I got very interested in studying how to make blood products in a more effective way and also how to use them in a more effective way for patients with life-threatening bleeding. After that experience, started to publish on our experience in Baghdad, working with a bunch of other people around the world, have been continuing that research, focus, and developed a public charity called the Thor Network, which stands for Trauma, Hemostasis, Oxygenation Research Network. And it's an international group of both military and civilian providers that spans everywhere from the pre-hospital provider, the medic, paramedic, all the way to basic scientists, ethicists. We have family representatives, patient representatives, et cetera. So very multidisciplinary. And our goal is through training, education, research, and advocacy to improve outcomes for patients with life-threatening bleeding.
Yeah, I think I noticed the Thor Network. You had a conference in Perth. Was that in 23 or something? Is that right? Or 22?
That sounds, yes, it would have been 23. Correct.
No. And any more of those lined up in the future that we can organize some of our members to come along and visit or join in with?
Well, that's an interesting question. We had one lined up for 2025, but for multiple, how do I say this? Multiple unfortunate events, we wound up canceling the 2025 meeting. But we have talked about potentially coming back at another time, but probably not to Perth.
No worries. Well, keep us posted so that we can let everybody know. So I think I'll start with the big one for me is talk to me more about working as a military doctor and that sort of environment and the differences that you experience with the care that you deliver. So, you mentioned that you're a pediatric.
Yeah, pediatric training, although many people think that doesn't really match a military combat setting. But if you think about it, pediatric trained, especially intensivists, treat teenagers. And we're trained to even deal with adolescent medicine and the adolescent mind, right? Which is young and different, right? There are certain aspects of adolescent medicine that if you're not trained in it, it's kind of hard to know how to deal with the 15, 16, 17-year-old.
Yeah.
Well, how old are our soldiers? 18,
Well, I'm guessing
20.
17 onwards, are they? Or
They're very young, so it's fairly similar to adolescent medicine. So pediatric practitioners, and especially pediatric critical care, I think are very well trained to take care of injured soldiers. You asked what's different about military medicine. I think two things, and it's very obvious if you ever experience it. The severity of injury that occurs in these combat casualties is much, much more than you'd ever see usually, back home in civilian settings. Is either, a single penetrating wound to the chest or blunt head injury or extremity injury, or maybe sometimes pelvic fracture, right? One at a time. In the military setting, you get all of it.
yeah,
All of it. Head, chest, pelvis, abdomen, extremity, burn, all in the same patient. So the severity of injury is usually much more than you would see at home. And then you got to take care of those much sicker patients with a lot less equipment and other capabilities than you have at home. So sicker and usually less equipment, less tools, and maybe even less specialists that you have available to you too. So it makes it very, very challenging, which, from some perspectives, the challenge made it, I don't want to use the word fun because fun is the wrong word, but it made it interesting, kept you
engaged.
Challenged, engaged, but also at the same time, very depressing, very sad, very to see so many kids, die.
Yeah.
Or become very, very injured, double, triple amputees. So very frustrating, very rewarding, very challenging, interesting, exciting, make you angry, all within a 5-minute period.
Yeah.
Yeah.
I guess for me, obviously, I don't have that military background, and Australia's, we obviously have our army and so forth over here, but for the majority of the pre-hospital clinicians that would be listening in here, they probably don't have very much military experience. So what I'm picturing for you with your military setup and your hospital there is tents and all that sort of stuff. Is that right? Is that how you build
No,
these?
normally,
Yep.
almost always, but I deployed into Baghdad.
Okay.
So
Yep.
we were in the middle of the city, and Saddam Hussein had his own hospital for his family and high-level Baathists. So instead of setting up our tent, we took over Saddam's hospital called Ibn Sina,
Oh, you're right. Okay.
and after a philosopher from the region, and we worked in his hospital, which was
Yeah.
much better than working out of a tent.
I can imagine. Yeah, absolutely. And so I'm picturing it, a incident goes off, soldiers are injured. I'm assuming a medivac operation where they go and pick up and they bring the patients to you. Now, injuries wise, as you've mentioned, probably a lot of blast injuries, burns and so forth that you mentioned. I think Alex is about to join us in a moment, which is great. Al, this is Phil. Al. And we're just talking about Phil being over in Baghdad at the moment and some of the patients that he would get to see being medevaced in. And so significant injuries, your team that you would have over there would be your normal trauma configuration that you would have in an emergency department back in the States, or less a few people?
I guess maybe normal configuration, but just a lot less.
Yeah.
Medicine had a few trauma surgeons, but had some other general surgeons. We had an oncologic surgeon there at the time. We had an obstetrician with us at the time. Had a dermatologist, there at the time, and people would just do their best, with
Yes.
the training their background. But we would all learn from each other, and help each other as much as we could. Even had two hematologists, interestingly.
Well, that would have been very handy, I imagine, which is probably where some of your research led into as well. So, for your perspective, think about your environment that you normally work in within a hospital setting and the busyness and that. Do you feel that in that smaller, more controlled, less people around, did your job seem to go better or smoother, like run better without the crowds of people? I certainly know from our pre-hospital experience, a cardiac arrest management, say in our environment where you've got 4 people turning up and everybody's got a
Yeah.
dedicated job, things run really well. Sometimes numbers can make it too messy.
I wouldn't say having less people made it better, because it meant we were always on call. I mean, 24/7.
Yeah.
There was there was very little downtime, very little time to rest. I don't think it made it easier. I think it made it harder long term, because you just had for a year. I was
Yeah.
there for a year. Some of the surgeons were there for 6 months at a time. The non-surgeons were there for 12 months. So imagine
Yeah.
12 months, you
Yeah.
know, you run around empty pretty
Yeah.
quick. So it can be very, that's what I'm looking for, a very, mentally taxing, or
Yeah.
just exhausting.
Yeah.
But what did make it easier to be more creative in what we were doing, and allowed us to be creative, and that creativeness, so to speak, led to a lot of major changes, is that we didn't have all of the constraints you normally have in a civilian hospital. There weren't people walking around and telling you, well, you can't do that. You can't,
Yeah.
you weren't worried about lawyers and
Yep.
legal risks. We did what was best for our patients. And what was best for our patients was giving them whole blood, right?
Okay.
Not legal, not the whole blood we use was collected from each other and given to the casualty within a half an hour. We didn't
Wow.
we couldn't test it for HIV, Hep B, Hep C. And we were able to do that because we weren't worried about the legal consequences of doing so. So having that freedom to do what you felt was right, what was best for the patient, and not some administrator telling you you can't do that.
Yeah.
We said we're going to do what's right, and we're going to document it, and we're going to, go home and kind of, test it again and see if it holds true at home as well. The biggest difference was not having that legal constraint.
Yeah. So let's go back to that situation where you are there. Obviously, administering blood to the patients as required. Speaking with Mark Yazer, talk to him about the dirty word of normal saline. What sort of volumes of normal saline were given back in those days, or was it straight that you would be pushing for whole blood?
Well, of course, when we started, we were starting with the usual paradigm of giving fluids first, and then red cells, and then, eventually plasma. We had no platelets available to us in 2004, 2005.
Okay.
So that's all you could give. Interestingly, with my pediatric background, I trained in Philadelphia, pretty much one of the only places left in the U.S. that was still using whole blood daily. So I had just gotten out of fellowship in 2003, where I had used whole blood every day in our children's hospital. So I go to Baghdad and I say, hey guys, where's the whole blood? And they look at me like I'm crazy. I said, come on, whole blood. Like, what are you using just red cells for? And they said, Phil, like, we don't have that. Nobody has that. I'm like, well, I just left Philadelphia and we were using it every day. So again, I'm tired of pronouncing young soldiers dead every day. And so I said, guys, we can't do this. I'm not doing this for a year. We got to find another way. So I said, I did it in Philly. Let's find a way to do it here. Of course, the military started, right, using whole blood back in World War I. We kind of used that same old approach. And between 5 or 6 of us, we developed our walking blood bank system there. As a result, the difference was so dramatic between using the saline, red cell, and plasma approach. And then when we started to use whole blood, the shock resolved almost immediately. The coagulopathy often, very immediately was resolving, changing. And we said, wow, like this is a major, major difference. So we slowly started to bring whole blood instead of a rescue therapy at the very end of a resuscitation when the patient was about to die. We started then using it earlier in the resuscitation and then earlier, to the point where when we got a phone call saying, hey, we got 12 casualties coming in, 6 of them are massively bleeding, we started our whole blood drive before the helicopter even showed up.
Yeah, bro.
And that was between April, August, months, right, of going, we got to start using it earlier and earlier and earlier. By October, we wrote our protocol to use whole blood, as a standard product. And the year I was there, we used over 800 units of whole blood in, I would say, a 9-month period, because it kind of took us 3 months or so to kind of ramp it up.
Yeah. And so when you say a whole blood drive, is that everybody over there that's donating? Is that you're trying to get people donating over there?
When we set up our system, we were pre-screening donors. We had about 6,000 soldiers within within the center of Baghdad where I was stationed. So I went out to each of the bases and said, we need to collect blood from all the soldiers to resuscitate any of our casualties when they come in. Would you be willing to be a donor? And almost everybody said yes. So we would ABO type them, and we would do a kind of a rapid or mini screen questionnaire to make sure that they would be safe to be a donor. So pre-screened, we got their ABOs ahead of time. So we had literally a roster at every base to know who was Group A, who was Group O, B, etc. Back then, we were typing the casualty and giving ABO compatible blood.
Yep.
It's not like we're doing it now where we're only using Group O whole blood and giving it to everybody. Back then, we were typing. So having the donors type ahead of time was very, very helpful. And that's how we set up the system. So that when we had those 12 casualties come in, 6 massively bleeding, we were calling those bases to say, send over 6 of your O's, 3 of your A's. They'd come into the front hallway of the hospital. We'd put them in a stretcher, stick out your arm, put a needle in it, let the blood collect into a whole blood bag over 10, 15 minutes. The first aliquot that came out, we would test for hepatitis and HIV with a rapid test. So we weren't doing the formal testing that you get in the hospitals now, but it was a rapid test that was a lot better than not testing at all. After 20, 25 minutes, now the bag is collected, it's tested, we would give it to the casualty, and that's how we developed our walking blood bank.
That's fantastic. That is amazing. And so volume-wise, out of your patients, 500 mils roughly, is that about right?
Yeah, 500, yeah, 550. Yeah.
Yeah, amazing
And,
stuff.
and it goes in more.
It would do, yeah. So taking out one of the lethal parts of the trauma triad type
Yeah.
stuff.
Yeah.
Yeah, that's great. Interesting. What about TXA? So, like, I think one of the problems with all this sort of, fractionated, giving some people red cells and platelets and stuff, we also have to give some of these other components, calcium, TXA, that sort of stuff. Do you find
Yeah.
the benefits of TXA in that setting?
I do think there's a benefit of TXA. Not only is it an antifibrinolytic, it also helps protect endothelium too, actually, which might even be more important than reducing the fibrinolysis. The evidence is pretty good, right, in large clinical trials. I mean, the impact is fairly small on mortality, but I think it's worth giving. I give it routinely in both children and adults. I think it's important tool in
Yeah.
addition to the whole blood, right? I heard you mention calcium. Calcium is real important. Citrate, chelate the calcium, and calcium is important not only for hemostasis, it's also important for cardiac function too. And if you have reduced cardiac function, reduced cardiac output, you're going to lead to reduced offspring delivery, more coagulopathy, more endotheliopathy. So, but I prefer, honestly, I would prefer to measure the ionized calcium and then replace it only if I know it's low. A lot of people are pushing, give calcium after 1 unit or 2 units. Mostly where I work, there's always a point of care test that allows you to measure ionized calcium. If I was in a place where I couldn't do it, I probably would do it empirically, maybe after 3 to 4 units. But thinking about other adjuncts, fibrinogen is important. I think some patients may wind up having increased hypofibrinogenemia more than others. So again, it would be better to have it be goal directed. Aren't very good point of care tests yet. Some companies are working on them for fibrinogen. Some recent studies have shown empiric use of fibrinogen to everybody has not improved outcomes. But there are certain patients that need it. So it's important to be, if you can identify who has low function, you can get a sense with viscoelastic assays in hospital now. Right? Your focus is pre-hospital. No one is bringing a TEG, or you really can't. Although there are some companies developing point of care coagulation monitors that can be brought pre-hospital. Although I don't think they're not licensed yet to do so.
Would be making it very busy, pulling all those things and getting samples and so forth at the same
Yeah.
time when you main focus.
Not always time. No, but if you're in a helicopter and you had a 30-minute transport, or even a ground ambulance that's going to take, 20, you're out. If you could get a sample, wow, look, they have low fibrinogen function. Let's give them fibrinogen concentrate. Or now there's companies making a dried cryoprecipitate product. And I like cryoprecipitate as a fibrinogen source better than fibrinogen concentrates in isolation, because cryo not only has fibrinogen, has von Willebrand, which is very important for platelet and adhesion aggregation. Factor 8, same thing, as well as factor 13, helps reduce, it stabilizes the clot and is less risk of fibrinolysis as a result.
So TXA in that environment then, so what is your recommendation when it should be administered? How long into the case should we administer, and when should we go to TXA's?
For a patient that is massively bleeding, for a patient with life-threatening hemorrhage, I think it should be given as fast as possible. And often as you're kind of getting the blood ready and set up to give, a bolus. I bolus it. I don't give it over 10 minutes. Very few people still do, at least in the pre-hospital setting, even in the trauma bay. We've published pharmacokinetic data showing that a bolus push has very, very minimal changes in the pharmacokinetics. The peak does not get much higher than if you gave it over 10 minutes. So just push it.
That's certainly the way within our service you often find that it's actually given as more of a push. I think that a terminology states that you should give it as a slow push, but I think you'll find that it's probably given a little bit quicker than what is stated in the guidelines. We can move on to pediatrics, obviously you've got a wealth of experience with pediatrics, and we've got quite a junior group of people that follow us, as well as some higher end clinicians too. Pediatric tips, mate. This is, people ask us all the time, we want to know more about looking after pediatrics. So can you give us, this puts you on the spot, what are some of the top tips that we can tell pre-hospital clinicians about caring for pediatrics, or also assessing them?
Yeah, it's funny. I'm smiling because I just came home from Poland last week, where we had a conference on pediatric trauma to help the Ukrainians with their assessment and treatment of children that are being injured in Ukraine. And the biggest message there that the pediatric specialists gave to the adult doctors was there are a lot more similarities in how to treat a child compared to an adult than there are dissimilarities. If they are massively bleeding, treat them the way you would treat an adult. Give them whole blood as fast as you can, follow the hemodynamics, and stop the blood when they've responded. There's no reason to limit the blood products that we give to children that are massively bleeding. There's no reason to limit the whole blood. They can get it. They can be resuscitated with blood the same way we treat adults. There should be no maximum dose, and there should be no minimum age, right? If for some reason a 7-day-old was having massive bleeding, that 7-day-old should be getting whole blood. There really is no good biologic reason not to give it. Pain control is real important. From the same ages we use for pain, ketamine, we use it routinely. It's a great drug for pain, anesthesia, and so there, no difference as well. Mechanical ventilation or airway management in the setting of hemorrhage, same thing. Resuscitate before you intubate.
Yep.
Anything in a child. Trying to think, what else? There is more head injury in children. You got to be more aware, or maybe have increased index of suspicion of head injury in a child. And that's because the size of the head of a child relative to its body is bigger. So it kind of gets knocked around more, so to speak. Neck, musculature is going to be weaker as well, too. And the younger child, they're lower to the ground. So if you're getting blast injuries in combat situations, heads could be injured more as well, too. So, but how you treat the head injury is the same. Avoid hypoxemia, avoid hypotension. If there's concern for herniation syndrome, same approach. It really is no different in how you treat traumatic brain injury in children, but they do get it. It does occur more often. Clearly, tourniquets, right? You have to find something small enough to fit a child, but you should still use a tourniquet the same way you use it in an adult. The biggest difference is dosing, right? You got to know the doses of the ketamine, of antibiotics that you're giving to a child. And there are groups here in the U.S. that are, I think TCCC is putting together a pediatric module that has like a, what a broad flow tape is? You have broad flow tape? So something very similar that's more military relevant, and that it's not available clinically now, but it will be soon. It's just an easier way to provide a guide, an aid to adult, practitioners who don't know off the top of their head the dose of calcium.
So I don't know if
That's
you got
right.
a question at the moment, Alex, but I'm thinking I'm taking you into the blood as well, still here for the moment, Phil. So you say there's no upper limit, but what's your starting dose? Do you go 10 mils per kilo for blood administration? Do you have something that you say to people?
We are talking about a child with life-threatening bleeding. If their pressure is 40/20,
just open it up.
No, we don't use a dose. I slam that unit in as fast as I can, and I'm watching the blood pressure. I'm examining the child, right? I'm watching the heart rate. I'm pushing it in as fast as I can. I try to advise people to be careful if you're using a 10 per kilo dose. Then if you give the volume, then you stop. Then you look. Shit, the patient's still hypotensive. Now I got to start it again. You're delaying care. Give the whole unit, but you got to watch. Don't tell the nurse or somebody, well, give that unit and then walk away. Right? Then you could harm the child by giving them too much. but use what you have available. Don't limit it to 10, 15 per kilo, because then you will stop, right? Because the dose has ended. You first have to notice the dose has stopped, okay?
Yeah.
Right? And then, all right, what are my hemodynamics? Oh, shoot, it's still not resuscitated. Okay, now start again, right?
Yeah.
Okay, with 10 minutes, they got to do the math. You got to get the dose. You're delaying care. Push it in, treat to effect.
That's a very good approach. I like that. Alex, what are
As
your
long
thoughts?
as as long as you're watching.
As long
Right?
as you
If you're not going to be able to watch, then it might be
Yeah.
better to give a dose at a time so that you don't over resuscitate.
Very good.
I loved all the stuff you were saying about pediatrics and how to treat them, and it sounds like a lot of the stuff's similar to adults. Which,
It is, other than
I
the
think,
dosing.
yeah, I think
Principles
people
are
are
the same.
worried about pediatrics because any sort of lecture at
Yeah.
uni learning about this, peds are not small adults, and it puts the fear into everybody that kids are so different. But
And that's true. That is true, but it mainly is reflected in the dosing, right? I mentioned head injury is more common, so you have to be more aware of it. But if they have it, the treatment is very similar. The pathophysiology of hemorrhagic shock does not appear to be different. Fluid shifts occur faster too. So if the patient has abdominal compartment syndrome, right, and they have a lot of ascites, and you stick a needle in to draw off fluid, if a child is only 10 kilos, you can't take a full liter of fluid off of them in 10 seconds because the fluid, they will become very hypotensive very quickly. And I'm telling you this story because it is exactly what happened when I was in Baghdad working with an adult surgeon, where we had to take fluid off a child's abdomen. And we started, and I didn't think he was just going to pull, basically a full liter off in 10 seconds. And as it did, the kid's blood pressure crashed because that fluid is moving from one compartment to the next to replace what was in the abdomen. And you just got to do that more slowly. But
that makes perfect sense to me. So I'll take you down another path now towards pediatric airway management. And recently we've had changes within Victoria with regards to pre-hospital pediatric airway management. And we had a bit of a older style approach to the way that we did drug facilitated intubation. That has changed now, and it's been removed for all clinicians on the road ambulances. Over there in Pittsburgh, what's the approach for pediatric patients with head injuries and so forth? The pre-hospital clinicians, what do they do? Are they intubating? Are they LMA or just airway support?
We are trying to teach to only intubate if you really must intubate. Now, you're saying head injury. If they're not able to protect their airway and it's a long transport, they're getting tubed. But if they're bleeding, right, we're telling them resuscitate before you intubate so that you don't have cardiac arrest by reducing preload, right, which will lead to cardiac arrest when you change them over to positive pressure ventilation when you intubate. But no, for TBI, if they can't protect their airway and you want to normal ventilate them.
Yep.
Then intubation is appropriate. Not using LMAs.
You're not using LMAs for children
No.
very much? No. Okay. And medication facilitated intubation, is that a thing in the pre-hospital environment over there for pediatric patients as well?
Unless they're obtunded, right? And if they're peri-arrest and you don't need to induce them or paralyze them. But giving a sedative and a paralytic is standard. Yes.
Yeah. Okay. No worries. So airway tips. So we've got an ambulance crew who's in the back of an ambulance with a 3-year-old child. No, make it 2. So a little bit chubby, has got those rolls, is quite hard to manage, small mouth, big head, big tongue, all those sorts of things. We've got a junior crew in the back of the ambulance. What tips can you give them now that make life a little bit easier for them with regards to managing a pediatric airway?
Well, as soon as you said chubby, right, I'm like, getting IV access is a bitch, right?
Yeah.
So if they need access for something emergently, right, put an IO in.
Yeah.
Right? IO started in pediatrics, right?
Yes.
So it's routine for us in the ICU, but pre-hospital, if you need access, and the child is very, very sick, right? You don't have time to get the IV in. Don't be afraid to use an IO. If you do need to intubate because of the head size, you will often need to put a roll under the shoulder to get the right line of sight. Normally in an adult, they could be like in a neutral position. In a child, a little bit of a roll under the shoulder, slightly extended.
Yeah.
When they're on their back, like the top of the ear should be kind of close to the anterior part of the shoulder. If I had a mannequin in front of me, I can kind of show
I understand what you're saying.
what I meant, or what I mean by that. Having somebody help put some cricoid pressure. If the airway is too anterior, as you're going to visualize the airway, give me some cric pressure, right, to bring it vocal cords down into view. Sometimes the mouth is really small too. Having somebody, pull
it open.
on the side to help see. But what else in the back of an ambulance?
What about manual techniques? Because a lot of our paramedics are advanced life support paramedics that don't intubate at all. So they use adjunct airways, as in nasopharyngeal airways or oropharyngeal, or do manual readjustments. So any tips with regards to placement of fingers, or you've mentioned position already, any other tips with any of that stuff?
I mean, the size of the NP airway, the size of the oral airway, right? You have to get the right size.
Yeah.
If you get too big of an oral airway, right, you'll wind up obstructing the airway. Well, for oral airways, right, if you get the airway, it should go from the corner of the mouth to the thing.
Angle of the jaw.
Now I'm getting, I think it's the ramus of the mandible, right? Am I right? It's here to here. A nasopharyngeal airway from the nares back to the tip of the ear is the right length of an NP airway. Again, the Braslow tapes kind of have that type of information, but if you don't have that, you can use those landmarks to know the right length of either airway.
Yeah. Alex, what do you got?
Right. We can't have Mr. Spinella on without talking about damage control resuscitation, surely.
Mm-hmm.
This is written a book about this, haven't you? What is it? What does it mean?
Right
What's
there.
the principle? Where did it...
Right there.
Proudly beautiful. Yeah. So, where did this idea emerge from, and what are some of the principles of damage control resuscitation or surgery?
Well, damage control resuscitation is a bundle of care, right? That's aimed at improving outcomes by reducing death from hemorrhage. John Holcomb was the person that kind of coined the phrase and kind of put together, all of the principles of damage control resuscitation, right? The first one is rapid surgical control, right? Don't waste time in the field doing this, doing that. Get the patient to a surgeon as fast as you can. In adults, there's this concept of permissive hypotension that many people are starting to question now, because we're using blood now, and where it might be okay to bring the pressure up a little bit, and you won't pop the clot the way you did with crystalloids, right? Hypotensive resuscitation was kind of thought about in the 90s when we were using fluids. And if you bring up the pressure too quick with fluids and you're diluting the coagulation system, right, you're going to pop the clot, they're going to bleed more. But now we're using blood. And if you are hypotensive, you're reducing perfusion to the tissues, to the endothelium. That's the cause of trauma-induced coagulopathy. So let's use blood. Let's bring up the pressure more than what we thought we could, right? And not cause TIC, and very likely not have an adverse effect of popping the clot. So permissive hypotension is still like within the table when people talk about DCR, but many of us are starting to say, well, you can be a little bit more liberal with that blood pressure when you're using blood versus when you're using crystalloids. A hemostatic resuscitation, the balanced use of blood products for patients with life-threatening bleeding. So either using whole blood, or if you can, components in a 1:1:1 unit ratio, not using crystalloids. Even in Baghdad, we eventually, by the end of my year, took the crystalloids out of the emergency room for patients with life-threatening bleeding. No If it's not there, you can't use it. We had whole blood, red cells, plasma in our emergency refrigerators. The clear shit got taken out, right? You've heard the saying, blood is for bleeding, salt water is for cooking pasta, right? Salt water is great if you want. Actually, I was telling Matt, I was making dinner before this started. I'm making pasta. Okay, I put salt water in there to make it boil faster, okay, and make the pasta taste a little saltier, better. That's what it's good for. It ain't good for bleeding patients.
You got a bag of saline
I'll ask
from
you this
hospital.
question. I was going to say, do you get charged for the saline that you take from the hospital to cook your pasta, or do you just
Yeah.
you got your own supply? Now, so look, I'm very wary of the time, and we've kicked over 43 minutes already, Phil. So we'll close off with a couple of questions. Now, I want you to think about yourself when you first started your medicine career. What advice would you give to yourself as a person with all this wealth and experience now? What would you give to junior Phil?
The most important word in medicine is why. Ask why. Why am I doing this? Why are you teaching me this? What's the pathophysiology? But why? Why am I doing this? There's so much dogma out there that is bullshit. Wrong. Just plain old wrong. And if you don't ask why you're doing something, you don't understand the principles behind it, and then you might realize you could be doing it better. Yeah. So ask why, when you're being taught something. Sometimes the young kids will find out the people who are teaching them don't know why.
Yeah.
They're doing something, that's because what the book says. Well, why
does the way we've done it in the
does
past?
the book say I should be using a masked trouser?
Yeah.
Maybe we shouldn't be. Why are we using saline? Why am I slow pushing TXA? Why are the platelets not cold? Why is plasma not dried? Why am I thawing it when it could be made in a dried formulation? Ask why. Don't be afraid to ask why. That's, I think, my biggest advice I would give.
Wonderful. I like it.
That's great.
Alex, one last question to finish off.
Yeah, rapid fire round at the end. What frustrates you most about modern medicine?
What's frustrating most about modern medicine?
Yeah.
The amount of time it takes to license a new product, the regulatory constraints that are harming patients. They should be there to reduce harm, right? But it's become so restrictive. I just mentioned dried plasma a few times, right? You don't have dried plasma available. We don't have it available because the regulatory bodies torture the people who make the dried plasma, and that it takes many, many years to get it licensed. That's what's most frustrating. We have good therapies that patients need, and they're not getting it because of the regulatory hurdles that are required. I mean, the regulations are important, right?
Yeah.
But we should be more efficient so that we can take these advancements to patients a lot faster than we are now.
Yeah, 100%. And I guess you need to look at research. And when you produce research, it's done over a couple of years. But to get that information out and into practice in a lot of environments can actually take, what you say, Al, in the other episode, 10 years or so forth with some research to actually get out there and being used. So, Phil, I'll wrap it up there, mate. I appreciate your pasta's probably overcooked at this stage, but I really do appreciate your